You're listening to the Jefferson Exchange. I'm Charlie Zimmerman. On this Mental Health Matters, host Andra Hollenbeck talks about living with depression.
Hello, hope you're all doing well today. You're listening to Mental Health Matters on Jefferson Exchange with the Jefferson Public Radio and NAMI, Southern Oregon. I'm Andra Hollenbeck with NAMI, the National Alliance on Mental Illness, Southern Oregon. When we talk about health, we cannot discuss the complete health without talking about our mental health. On this program, we highlight mental health issues in our community and ways we can improve mental health for everyone. Today, we're talking with Deborah Serrani, an award-winning author, a 30-year practicing psychologist, and professor, discussing her book, Living with Depression, A Comprehensive Approach to Living and Living Well with Depression. Good day, Deborah. How are you today?
I'm doing well, Andra. And yourself?
Good. Thanks so much for joining us on the program.
Happy to be here.
Good. So there's so much good information in your book. I had a difficult time figuring out where to start our conversation.
Aww.
But let's start with your firsthand experience with depression and your struggle to find treatment, because it was both enlightening and hopeful. I found your book to be sort of a combination of memoir, self-help, and guidebook.
You read it then.
Yeah. So you seem to have kind of a unique perspective as a psychologist and someone living with depression. Can you share with us just some of the crucial turning points in your life when you learned about yourself, your illness, and how to pursue treatment?
Well, I was a teenager, 19, and I was commuting to college back in the day where there weren't cell phones or even answering machines. And all my friends had gone away to school, and I thought that I was just feeling isolated and disconnected. But I started to slip further into a real sad hopelessness, to the point where I wasn't getting out of bed. I didn't care if I ate, and if anybody knows me, that's like a huge thing. Mm-hmm. I was sleeping all day. I didn't have anybody really checking in on me. My parents were working, my sisters were out, so I was left to myself to get to classes, and slowly but surely I never got there. Mm-hmm. And I really descended into what I learned was a major depressive episode. Mm-hmm. And I had very bad thoughts and had suicidality that was very dangerous. Mm-hmm. But I had a close enough relationship to my family. I reached out to my mother when I had a full-on plan set up. And I said, Mom, I need help. And she came home, and that day we found a therapist, and within a few days I was in the therapist's office. Mm-hmm. And at 19 years old, I discovered that I had a major depressive episode. So up until then, I knew that I had these bouts of sadness, but what I came to really discover was that all my life as a child, I had what was called dysthymic disorder, which is now called persistent depressive disorder. I didn't know any of this, and neither did my family. It was a chronic, low-grade depression. And it set the stage for the trigger of college time to really be a risk factor for me to fall into a more depressive episode. It saved my life, it changed my life, and I wanted to pursue a degree in it. So that's how I got to where I am today.
Oh, okay. So it sounds like you weren't able to identify this as depression right away, that seeing the therapist helped you identify that.
Right.
And so was that a relief to you, or was there some resistance there when you first had that diagnosis? Kind of what was it relief, or was it like, no, this can't be true? Or...
For me, it was a great relief. Mm-hmm. I was in such bad shape, and it helped me to understand that I had an illness, mm-hmm. that it wasn't, I wasn't trying hard enough, or I have to push myself to do things. This is like a medical illness, but more brain behavior. Back then, we really didn't talk about it openly like that. I was relieved. Mm-hmm. I was relieved it had a name. I was relieved there were things we could do. And the therapist I had was wonderful, and I met all of the levels of response and remission without medication back then. Mm-hmm. And I came to learn that, a lot of the more chronic illnesses, especially in the DSM, are often missed. Mm-hmm. It's the squeaky wheel that gets the oil. Yeah. So if you're somebody who's highly depressed and people think you're suicidal, you'll get the help you need. But 90% of people are quietly suffering or actively enduring symptoms without really letting others know.
Mm-hmm. Right. And in your book, you explain kind of, all of the characteristics of different and the nature of mood disorders. And I like the way you talked about both the biology and the biography of mood disorders. And how did that help you in pursuing your own recovery as you kind of understood the interplay between biology and biography?
Well, again, when you live and you learn, you acquire this knowledge that helps you make sense of things.
Mm-hmm.
And during the time of my own therapy and during the time of my training, the theory was that biology and genetics really have us pre-wired for certain things: brown hair, brown eyes, things of that nature, and that the environment or your biography, the world you live in, the traumas in your narrative or triggers that occur, can set into motion this epigenetic switch to turn on.
Right.
So the nature-nurture theory plays a very big role in our well-being. And the more we know about our family lineage, history, things of that nature, the more we can kind of prepare ourselves and make sure we can tamp down on certain triggers or difficult moments if it's going to be vulnerable for us. So it's always, when I work with patients or when I'm teaching, I'm always making sure that people understand the biology that they themselves have and also making sense of the world they live in, because every single person's illness trajectory is going to be unique.
Mm-hmm. So when someone is experiencing some depression and they're looking at that, what are some of the factors that people should consider when when deciding if, okay, is this depression? And
that's such a good question, Andra. There are three areas that we look at. We look at cognition, because mental illnesses affect how we think. Mm-hmm. Is there difficulty concentrating? Are you having trouble with your thoughts? Are they foggy? Are they negative? Are you finding yourself feeling hopeless? So we want to look at the cognitive pieces to a child or adult to see if the symptoms of depression are operating there. And then we also want to look at the physical level of mental health. All mental health symptoms, it's mind-body. Mm-hmm. So with depression, we have fatigue, aches and pains. We have stomach issues, digestion issues. People can have a slow gait, a slow speech. Essentially, I tell people that depression depletes you, anxiety overexcites you. Oh. So when we look for the cognitive piece and the physical piece, we then look at the behavioral pieces. How are you feeling? Are you feeling good? Are you feeling sad? Are you feeling helpless? Are you feeling lonely? Now, the range of human emotions has all of these things.
True.
But if it affects a child's daily living or an adult's day-to-day activities where they're sad, they can't think well, they're just not themselves day in, day out, that's when we start to worry that illness may be operating. Mm-hmm. Okay. So it's time, the amount of time it affects you, and how it affects you.
Mm-hmm. So kind of time and quality of your life.
Right.
So you're listening to Mental Health Matters on the Jefferson Exchange. I'm Andra Hollenbeck of NAMI, Southern Oregon, and we are speaking with Deborah Serrani today, noting some of the things that she talks about in her most recent book on living well with depression. So there were a couple types of depression that were particularly surprising to me, and it made sense once I read about them, but maybe it's not something that people would not normally think about. You talked about post-surgical depression, and then you talked about prolonged grief, too, as different types of depression. How can we kind of elevate our awareness, be prepared to improve, in case some of these things kind of hit us?
Well, again, we use the Diagnostic and Statistical Manual clinicians do as kind of like a benchmark for what is considered healthy or maybe concerning behaviors. Mm-hmm. And grief has always been connected to depression, but grief is an appropriate, normalized moment that a child or an adult goes through. We don't consider it an illness because it makes sense that we're bereaving or mourning or grieving. But there's something about a prolonged grief disorder that's been noted for about a decade or so. These are individuals that really struggle and even shut down after the loss of a significant loved one. And the way that we learn more about it is to talk about it, like shows like this, television episodes highlighting certain symptoms, certain shows that show post-surgical depression. The more we can get this out there to the general public to understand that any trigger, surgery, the death of a loved one, moving, an earthquake, all of these things impact us. That's the biography that we all live through. So the way to kind of help learn more about it is to have these wonderful exposures through media to reach the general public to say, maybe what you're experiencing isn't just something that's going to pass. Maybe you need some support.
Right, and it does sound like that when these, like you said, we all have these kinds of variations in our emotional states, but when they come to the point where they're interfering with our life, that's when it becomes a problem and time to seek help.
Right, and one thing I'd also like to say to listeners is to make sure that whoever you're sharing this with is really listening to you, because many times people will minimize aspects of mental health. So, I always say the word listen has the same letters as the word silent. So I always want to make sure that when people are talking about their experiences, that another is really hearing them.
Yeah, that's a really good point. So some self-care is something that we hear a great deal about, and it's kind of bantered around quite a bit in our culture. And it can be challenging to implement really good self-care. And so I would love you to talk about how we can take actions for self-care, particularly when you find yourself in the throes of a mental illness and your mind is not necessarily working well. What are the actions we can take to help us feel better and take care of that self-care?
Well, I remember this as somebody early in my stages with my illness that I was really struggling to get certain things taken care of, like to take my medicine consistently, to make sure I was going to sleep on time and trying to eat well. And the more I learned in my professional career that there are reasons, biologically brain structure reasons, that it's hard for us. So I think one of the first things listeners can do is to understand that depression greatly affects the executive functioning of the brain. So, if you're struggling, try to give yourself a little permission to say, maybe this is hard for me because my depression is limiting my resources and my energy. And then once you can understand that this may be difficult for you, it could be something that you reach out to others to help bond with you while they can help you self-care. So you have somebody to remind you, somebody to be a guide for you, somebody to walk with you, somebody to just kind of support you until you reach a higher level of response where you can then do these on your own. And it is an art. We don't naturally know how to self-care. So it can be something that's very, very difficult at first.
You're right.
So start small. Be proud of the little things you do. If you're depressed and you can't get outside, but you moved into another room, that's a great start. To reinforce yourself positively for all of the efforts you make. And I'm a big believer in always trying to make sure you feed your senses. Like I said, there are some days I can't get out. My depression's just so overwhelming for me that I'll just open the window and I'll listen to the birds and I'll get the fresh air and I'll put some music on, even though I know my wish would be I'd love to be out walking by the beach and, having a little bit more freedom from my illness. So it's important to just be slow and steady and consistent.
We're listening to Mental Health Matters on the Jefferson Exchange. I'm with Deborah Serrani. I'm Andra Hollenbeck of NAMI, Southern Oregon, and we're talking about how to live well with depression. And it sounds like it is a matter of managing your life, not necessarily curing depression, but finding those kind of balances in your life. And you have something in your book I really liked called the 5 R's approach to understanding recovery. I think this can be helpful both for people who might be in the process of recovery, but even for the loved ones or the people around them that support them. So, would you mind just talking a little bit about your 5 R's?
And I love that you're highlighting this. These are actually not my 5 R's, but these are the 5 R's that we all hope any treatment, medical or mental health, an individual can go through. But I noticed that it's not really spoken about, so that's why I highlighted it.
Yeah.
And one of the first things we want to do is get to the first R, which is called response. This is where you see an improvement, not necessarily a big one, but you say, oh, I feel a little bit better. Like when somebody tells another person, I think I'm struggling with depression, or they make an appointment with a therapist, they come back and say, I feel a little bit better. This is what is the very first step in your healing journey. But what we really want to happen is the next R, which is called remission. This is when your depression is in a full state of not being, you're not experiencing, you're symptom-free from your depression. Now, most people in therapy or taking medication get to this place. They get to response and they get to remission. But not everybody gets to this third one, which is called recovery. This is where you have at least 4 to 6 months of a remission, meaning no symptoms, you're doing okay, and you continue with all of your skills and your treatment plan, and you keep moving forward. Most people don't stay. In fact, as they start to get better, they leave therapy or they stop their medicine because there's a natural feeling that, I guess I'm doing okay. I don't need this. Yeah, but then we fall into what's called relapse and recurrence. And this is where most individuals, children and adults alike, really need support with their mental health. It's really a daily management. That's what I've learned in my 30 years living with depression and practicing, that my own consistency and helping my patients maintain consistency.
Oh, that's great. So we want to talk just briefly about a very hard topic, which is suicide and its prevention. Mental illness and particularly depression are significant risk factors for suicide. So what is the connection there? What is it about having a mental illness that kind of leads us to that wanting to check out?
Well, I remember at 19 saying, it's just too painful. They'll be better. My family will be better off without me. And there's this very narrow thinking that happens with untreated serious depression. The executive functioning of the frontal lobe is not using reasoning and judgment.
Okay. So
we think we're making choices that make sense. And when I think about being 19 again, I can't ever believe I ever thought that way because I don't have that level of depression anymore. So yes, it's a very, very serious matter when issues like depression come into play. And there are certain warning signs and triggers and protective factors. And the more we can educate even those of us who struggle with chronic mental health and our loved ones what to look for, it can really interrupt what seems like a really solid idea, but isn't.
Right. And I've learned that it's important to, if you suspect something, to actually just ask and just come out and have an open conversation about it. Sometimes we're really shocked by death by suicide. It seems so surprising from someone that, it almost seems like it comes out of the blue. Obviously, there was something there. But do you have some insights into, how we can look out for each other a little bit better so that kind of thing doesn't happen?
Well, we know, I think there's human nature that we know if somebody is very sad and saying, I don't want to live anymore. We know just our own connection makes us say, oh, I'm worried about him or her.
Mm-hmm.
But there are other signs that are less obvious,
Right.
like when people start giving things away, when people start putting things in order, when teens and adults get all of their book reports and projects finished before the end of the quarter.
Mm-hmm.
When somebody suddenly moves from a very depressed state to a very happy state. In fact, that's when we worry the most. The highest level of death by suicide is not the holidays, Christmas time. It's the spring, when people have more of a physical activity burgeoning and swelling again, and they feel better. That's when suicide tends to happen.
Interesting.
So there are many things that can kind of slip by, but the more we become aware of just any behavioral changes, if somebody is suddenly doing something very differently, that's a good time to check in.
Okay.
And like you said, I happened to say to my mom, I was just going to do something really bad, and she didn't hesitate. She said, what is it?
Mm-hmm.
And I was so relieved that she did. And I think that on a subconscious level, there's some individuals that, really do need help and are asking for help and crying out for help. But then there are others that believe this is just what we should do, and I'm going to do it. And that's why we need to be their witness to interrupt this kind of unhealthy way of problem solving.
Right. It certainly seems like it's going to take a bit of awareness there. So once again, taking a little break. This is the Jefferson Exchange, Mental Health Matters, and I'm Andra Hollenbeck, talking with Deborah Serrani. And you discussed stigma, and of course, being with NAMI, that's one of the things we combat and work to get rid of. How much do you think stigma plays a role in people not reaching out, not seeking treatment?
Huge.
Yeah.
Huge. And you'd think, with all of the evidence-based data and science and news stories and breaking news of, finding the gene for this and the blood marker for that, it's still this elusive, scary, mysterious thing that people are afraid of.
Yeah.
The older I get, the less I understand, because there's all these wonderful breakthroughs that show that it's a neurobiological factor.
Right.
It's not lazy, weakness, crazy, psycho, dangerous. Most people with a mental illness are, the victim of a violent act, not responsible for one.
That's right.
So yes,
the brain's always been kind of a mystery, and so when something goes
absolutely,
wrong
Andra.
with it, it is a little scary, and maybe that has something to do with the stigma as well. And I have noticed it. I love that you brought this up in your book too, about professionals having stereotypes about mental illness and how
I could write a whole other book on that.
I know. It was so maybe talk a little bit about this diagnostic overshadowing that you talk about, and how and maybe a little bit like what people can do if they see that their health care practitioners are not treating them equitably, I guess, treating them as a stereotype instead of as a person.
Right. So, maybe the first thing we can do is say that what diagnostic overshadowing is when a health professional presumes that a physical symptom that you're coming in for is really the result of your ongoing or previous mental illness disorder. And because of that very narrow focus, or what I call lazy medicine, is that they foreclose great possibilities, tests, and discoveries of things that you really may be struggling with. So I noticed this in my own personal experiences with doctors who would who would say to me, what nonsense are you here for today? And what nonsense am I here for today? Well, nothing I'm going to tell you about, because now we're done. I'm not talking to you. And so in the pursuit of certain, I have Meniere's disease. It took about 2 years to get it discovered. I knew there was something wrong. And there was frequent diagnostic overshadowing. And then I decided not to disclose any of my personal history.
Right.
And I finally got the diagnosis from the experts needed. And it was an eye-opening experience. And I had known from working with many, many patients that this happens all the time, particularly individuals who have serious mental illness.
And if someone in that situation speaks out or says something, it's almost like they are not even going to be believed in
right.
that.
Well, or
as
now
well.
you're a difficult patient.
Now you're a difficult patient. Yeah.
It reminds me of the
irritable.
Seinfeld episode where they're putting it in your chart. That you're a difficult patient.
Right.
So some of the things to do is, and this is hard because if you're not feeling good and you're feeling vulnerable, and you also have, an anxiety or depressive disorder or schizoaffective, and whatever is part of your daily narrative, makes it hard to empower yourself and advocate for yourself. But that's what we need to do.
Okay.
So you take somebody with you. I have a note. I write a note, and I keep it in my pocket saying, I don't appreciate you using my previous depressive history in your current diagnosis of what I'm coming in for. And I have it. I take it out and I read from it if I don't have the strength and the fortitude to say it.
Wow,
it's time to look for another PCP.
Yeah.
It's time to find another expert. It doesn't preclude you from, voicing an opinion.
Right.
But we need to be careful because we fall onto this double-edged sword that, you're complaining because you're unstable. And no, I'm quite focused, and I'm perfectly able to express to you that you are burnt out or you shouldn't be doing this job anymore because you're not a diagnostician. You are somebody who's gaslighting me.
Right. So keeping a really level head and just speaking directly to the issue sounds like a good plan, and I like that little idea about carrying the note. So we just have a little bit of time left, and I just want to ask, if looking ahead, what are your kind of hopes or aspirations when you think about the future of mental health?
I would love stigma to be something that reduces even more. I would love for pharmacology research to really spend the time looking and developing medications and alternative treatments for serious mental illness and treatment-resistant illnesses. I'm hopeful for a lot. I think we've made some gains. But, that's why I love doing shows and workshops and segments and talking about mental health, because it's 1 out of 4.
Yes.
It's very common, and there's no shame in living with a mental illness. My depression gives me an edge, and I embrace it in many ways.
Right. It becomes a part of your collection of superpowers.
That's right, Andra.
Oh, great. Well, we have been discussing how to live well with depression with our guest, Deborah Serrani. Thank you so much for sharing with us today. Please find more information about NAMI Southern Oregon at our website, namisouthern.org, or email at info@namisouthern.org. This is Mental Health Matters. Thank you for joining us. You can find this and other interviews at thejeffexchange.org, or you can subscribe to this podcast at Apple, Spotify, or wherever you get your podcasts.